us, they'll be able to watch it later. So we should be recording right now. Does everybody have Johnny Depp up on their screen?
Yes.
All right. Let us begin. Mobility. Now, in your book, you might see it, classified as musculoskeletal, but we're trying to get into the idea of concepts because concepts seem to merge better with nursing diagnosis than actual systems do. But if you watch my video on concepts, you know what I'm talking about. What we're going to look at today, basic components of the musculoskeletal. Hopefully you all watched the crash course video because he is very funny and he's really good at reviewing the basic systems. And you all should have had that in anatomy physiology. So I'm not going to spend a whole lot of time on that. But we're going to look at casting reductions and orthopedic surgeries. Give you a hint, if you see this little guy anywhere, you may see that on a test, maybe. Hint, nod, nod, wink, wink. So moving on. Mobility. Mobility, pretty obvious what mobility is. It's the act of moving around, walking, exercise, activities of daily living. Your job as a nurse to help them maintain their mobility or to restore it if they're, say, post-surgical or post-trauma. So that's your job as a nurse. Take a quick look at these. We have flat bones, all like in the chest. Short bones are the hand and the feet. Long bones are the legs and arm. Irregular bones are those strange ones like the vertebrae, prosthetic hand, peg leg. Here are different parts of the bone. And you might hear us refer to that sometimes. You have a diaphysis, which is the center, and the metaphysis is the end. I'm not even sure I'm pronouncing that right. One thing I want to point out is when we grow, as we grow, the way we grow is from the end of our bones. We grow out from the end of our bones. And that is called, back up, that's called the epiphyseal plate. The epiphyseal plate stops growing about the end of puberty. So by the end of puberty, your bones are pretty much grown as tall as they're going to be. You don't grow much after that. And once that plate seals off, you stop growing. The reason I always remember this is we always discouraging anabolic steroid use in young athletes and young kids because steroids will make that epiphyseal plate seal off sooner. So, if you're taking anabolic steroids for the football team in junior high or high school, you're going to stunt your growth. Your epiphyseal plate's going to seal off early, and you're not going to grow to your full height. Moving on, osteoblasts. Now, we kind of covered this last year when we were talking about bone and blood production inside the bone and such. I know people are getting in the waiting room to come in. I'm going to change that so you can come in automatically. I didn't flip that switch when I created the Zoom meeting. Anyway, osteoblasts. The osteoblasts are the cells that mature. These guys create new bone tissue, basically. And then they become osteocytes, which become the actual fibrous tissue of the bone. But there are osteoclasts, which break down old bone tissue. I think I got another slide here, right here. Yeah, kind of help you remember that. Osteoblasts, with the B, build bone. Osteoclasts, with the C, crush bone or make bone, destroy old bone tissue. So you're constantly in the process of creating new bone and destroying old bone. It's an evolution. It's a constant process. If any of these get screwed up, then it causes a really bad disease. So osteoblast build bone, osteoclast crush the bone. Might see that again. Inside the bone, and we covered a lot of this last year when we were talking about red blood cell production. This is where your blood is produced. Now you'll have more yellow bone marrow down near the center of the bone, and you'll have more red bone marrow near the ends of the bone. And this is where the main blood production takes place in the red section here. But when it comes to people like Anthony Bourdain, that they always like I guess the bone marrow is tasty. I don't know. I'm not a bone marrow fan, but evidently that's gourmet in there. Not on humans, but on animals. I don't want you to get the wrong idea here. As we move into fractures, there's different kinds of fractures. You've probably ran into these or seen them or heard them before. Transverse is basically just straight across the bone, and then you can get some cracks. This is the one when somebody breaks their bone and it pokes out through their skin. The oblique displaced. This is a common one that you will find in children. No, I'm sorry, not spiral, the green stick. The green stick is a very common break in children. And the reason for that is as adults, our bones are kind of settled in and they kind of break and crack easily. In children, the bone is still flexible. So they have a tendency, and the reason they call this a green stick is if you've ever found a stick in the woods or whatever, and the wood in the tree is still green, still fresh, and you try to break the stick, you'll notice it'll kind of splinter. It won't break clean like this. And that's why they call it a green stick. But you'll see the green stick more in children, and you'll see complete fractures in adults. The commuted is just kind of where the bone gets crushed. They usually have to go in on surgery on that and clean this old material out. Now here is the stages of healing. Basically, when you first break the bone, it's just like if you were to cut yourself, all of the healing material rushes to the site, the white blood cells and such, and they begin to form. And that's where the osteoblasts come in. The osteoblasts go to the site and begin forming new vessels. I don't know if you ever see somebody, my wife shattered her collarbone one time, and the bones were apart. And they took an x-ray a couple days after the bones were apart. And it was really cool because you just saw these osteoblasts forming fibers in between the two bones. I mean, the bones were separated by, like, say, a good half an inch, and the body still knew to form tissue in that gap there. As you will find as you go along, usually when somebody breaks a shoulder or the clavicle, right up here, it's usually they just let it heal. You don't put a cast or anything on there, but kids like to ride their bicycles and fly over the handlebars and crack their collarbone. It's a very common injury. And you just let it go. And what happens is fibers will form in that gap and it will actually heal itself. Very cool. After the osteoblasts arrive, then you begin to form a callus, which is actually new bone tissue. And if anybody's ever, banged a bone or broken a bone, you'll notice there's a big lump there. And that lump is the extra callus, the extra bone tissue on there. Some of you may have broken a finger or something, you still have that extra bone marrow on there. Usually wherever you break the bone, it will actually wind up being stronger than where the previous bone was. But then over time, the osteoclasts move in, and the osteoclasts will kind of trim that down a little so that you're back to a normal bone structure. Anybody got any questions on that? So the osteoblasts move in first, build up the tissue, then the osteoclasts come by later and kind of trim it up like a woodworker, clean it up. Complications of a fracture. You'll notice when we were looking at the yellow bone marrow, if you break that bone, all that yellow stuff in there was fat, and that releases into the blood system. You have fat nodules running around your bloodstream. That's not good. That can cause a fat embolism. And fat, much like a blood clot, can plug off a vessel and cause issues. If that fat nodule goes to a lung, it can cause a pulmonary embolism. So you get a blood clot in the lung so that your lung's not functioning as well. So the other one, pulmonary. My brain is the one where you get a blood clot to the lung. Anybody remember what? God, instead of brain fart, TIA. Anyway, compartmental syndrome. Sometimes you'll be seeing that again. With a compartmental syndrome, you get a fracture or any kind of injury to the to a limb. Your tissue can swell up, and when your tissue swells up, it can clamp down on the blood vessels. And when it does that, then the blood vessel. Let me see if I can bring up my pointer option here. So if it swells up right here, down this, you're not getting blood to the distal part of your limb. So that can be a problem, and we'll talk a little more about that. Defective healing, the bone breaks at an angle and it heals at an angle. Usually the surgeon will have to go in and re-break the bone. I'm sure you've heard of that before. They had to go in and re-break the bone to get it to line up right. Avascular necrosis, that is tissue death. Necrosis means tissue death. If you sever or damage vessels, usually arteries, you can rob the distal portion of the limb of blood, and it can cause tissue damage. And infection, that's a big one. Always, well, not when you have an internal fracture, but if you have an external fracture, you got to be really careful, because especially if the bone is sticking out, you got a person's bone sticking out of the arm like that, not only can you get an infection of the tissue here, which we're all familiar with, but you can also get an infection inside the bone marrow. And that's when you get osteomyelitis, which is an infection within the bone itself. Let's talk about casts. I love this, jumping off buildings. Oops, wrong way. Let's go back this way. There are different types of casts. Plaster casts we're all familiar with. That's what she's got right here, or plaster casts. Those are usually done, it might be done in the ER. They're usually done in the bone doctor's office when you get a fracture. I'll explain that here a little more in a second. What we usually do in the hospital is a fiberglass cast. And anybody you've ever gotten a sprain or a break and gone to the ER, they have this material that's just kind of like a cloth, and you drop it in hot water, and as it dries, it's fiberglass and it hardens. But because it's soft, they can mold it to your hand. And then I got a picture of it in here. Then they just take an ace bandage and wrap it around it. That's just a temporary cast. Then when you go to the orthopedic doctor, usually it's in his office that he will put a plaster cast on whatever it is you broke. So this is usually used in the ER. We use fiberglass casts a lot. And here's an example right here. See, this is a cloth. This is a soft cloth. And you take it and you soak it in hot water. And then you just wrap an ace bandage around it. And as it dries, it hardens. It causes a little heat too, so it gets a little bit warm. That's just a temporary cast. When the person gets to the orthopedic doctor will put a plaster cast on it. There's a bivalve cast. This one is nice if you're having issues like compartmental syndrome, or you have an infection or whatever, because this is a regular plaster cast, but it's cut in half. and it's sealed with Velcro straps so that you can take it off and put it on. That's really convenient. How do you manage it? Well, if you're sending somebody home with a cast, here's a couple of things that you want to tell them. Always be sure to elevate it. If you have a leg cast and you're standing up a lot, the blood's going to pool in the cast. The cast does not expand. The cast is solid. So you get blood pooling in there. You can risk compartmental syndrome or just numbness because you're getting a lot of blood pooling. So you want to keep it level with your heart. If your arm, you want to keep it level with your heart. Your leg, and you're sitting in a chair, you want to prop the cast up on a chair. There we go. Keep it clean and dry. If it gets dirty, not good for the skin. If you have any kind of open wound, you have a risk of infection. There again, kind of going back to compartmental syndrome, observe for signs of swelling or infection. You always want to check the distal part of the cast. If someone's got a cast on their hand, you're always looking at their fingers. If they start turning blue, you're having circulation problems. If you get red or streaking, you can have the possibility of an infection. So you always want to keep a close eye on that. Neurovascular assessment. And this is what I'm talking about right here. Do we have our little guy? There he is. Always assess the distal pulses. Anytime you have a cast on the foot, on a leg, etc., you always want to keep an eye on the distal pulses. If it's in the hand, you want to check here. If it's on a foot, you got your pedal pulse. Very, very important. And also keep an eye on the color of the tissue. I mean, if you start cutting off the blood, of course, it's going to turn blue. Hang on a second. I'm back. So, moving on. Sometimes we have to reduce a fracture. Reducing a fracture just means basically pulling it apart. If you have a broken leg and the bones go like this, well, you're going to have to pull those bones apart so that they can heal properly. Otherwise, you're going to heal like this and you have a bad leg. So one of the things we can do is we can put traction on the patient, and the traction pulls the bones apart and lines them up so that they can heal properly. And that's what we got over here, this guy right here. I would say it's probably, his fracture is probably around here somewhere, but the way it's all set up, they got weights here that's pulling these bones in his lower leg apart. Now the lower leg, they have a tibia and a fibia, right? Y'all remember that from A&P. So usually when somebody is walking around and they get their leg broken completely, we call that a tib-fib fracture. And it's actually better, those two bones in the leg, it's better if you actually break both bones than if you just break one bone. Because if you break one bone, it's hard to get that bone. Say you just break the tibia, it's hard to get those bones lined up right because the fibia is still intact. If you break both the bones, it's easier to get them in alignment. And I'm not suggesting that if you go out and break your leg that you break both of them, but you know what I mean. Moving on. Reduction, there's closed and there's open. Let me see if we got some pictures. Okay. I think I got some pictures in the next slide, but a closed reduction is like he's got here. It didn't break through the skin. So we're just going to pull his leg and let the leg line up, align itself. That's a closed reduction. Open reduction is when we're actually doing surgery and we have to go in and actually line the things up manually. And usually you'll use that. We usually go along with fixation where we pull the bones apart and then we'll like put a plate over them. And I'm going to show you that here in a second. So you have reduction and you also have fixation. I'm going to tell you why that's important in a moment. Fixation is internal. Internal is like when we pull the bones apart and put a plate on them. External fixation is when you're seeing that big framework around the leg and you see the little things in it. I got pictures in here somewhere. Oh, okay, we're going to go into more detail here. Traction is a method of pulling structures of the musculoskeletal, like I explained to you. It also alleviates muscle spasms. Um, Back when I was a paramedic, if somebody broke their femur, which is your upper leg, if you break your femur, your muscles will spasm. And when those muscles spasm, okay, I'm getting some background noise, so you might want to mute your mic if you're not talking. If you break your bones, your muscles spasm and it'll pull the bones together like that. So we had a thing called a hair traction splint that we would put on their leg that pulls the femur apart. And the reason for that too is while it's spasming, the bones are grinding together, extremely painful. You ever see anybody with a femur fracture? They're going to be screaming their head off. It's extremely painful. That's because the muscle spasm is pulling those muscles together and they're grinding together, and it's very painful. So the hair traction splint is just a traction device that we put on them in the field to pull those femur bones apart. And that helps alleviate some of the spasm and it helps align the bone.
Bryce, just a quick question. Does blood thinners and other certain pain medications stunt recovery for bone fractures? Like when we're doing traction, like what kind of painkillers would they be on to deal with the pain with because I'm assuming traction is not very comfortable. It seems extremely painful. And then you said the femur is extremely painful. What kind of painkillers would they be on?
Morphine, heavy morphine.
That's what I was thinking.
Yeah, when we have a femur fracture, man, we load them up. They are in severe pain. And what's really interesting about that is they're in a lot of pain. And when we put the traction splint on initially and start pulling it apart, it's even more painful. But once we get the bones apart, they feel a tremendous relief. So actually, in the end, the traction will actually, when it gets those muscles stretched out and settled down, it actually provides some relief. It can actually be comfortable. So yeah, you would think pulling their leg like that, it would be painful, but no, quite often it's actually a bit of a relief. Now, people that are in a permanent traction device in the hospital bed, it's mostly just the immobility that drives them crazy, not being able to move around. But stretching the muscles out does provide some relief. But the painkillers don't impair the repair of the bone tissue at all. So we do not hesitate to use painkillers on people with fractures and such. Going back to reduction, closed reduction are things like slings, cast, bandages. Open reduction, like I said, is performed in the OR. That's where we actually open them up. I think I got some pictures in here. I'm pretty sure I did. Yeah, okay, here we go. Here's an internal fixation. Like I said, the closed reduction, we're basically just going to align everything and then put a structure around it. We're not going to open up the skin. So that's called a closed reduction. In an open reduction, we're actually going to go surgically open them up and go in there and attach a device to the bone to align the bones. And I'm sure we have all known people that have had this done. If you hung out with motorcycle riders long enough, I'm sure these are the people that set off the metal detector when they go through the airport. But sometimes you hear people say, "Oh, well, I got a rod in my left leg." This is the rod they're talking about. We put a rod in there to keep the bone aligned while it heals. And they'll usually just leave the rod there. Like I said, in adults, the growth of the bone is pretty much ended. Now, if you put a rod in a young child, at some point you'll have to take that rod out because the bone is going to keep growing. But in adults, that's usually not a problem. And here's different plates, different ways of lining up the bone and securing it. So when we talk about an open reduction, normally an open reduction goes along with an internal fixation. And you're going to see this term a lot in your nursing notes. Open reduction, internal fixation. Well, that means they opened them up and they went in and they fixed the bone with an internal device of some type. And where you're going to see this a lot is hip fractures. You're going to see left hip fracture, ORIF. That means they went in, they opened them up, And normally on a hip, I think I got some slides in here, but the knob breaks off on the hip. So they go in and they reattach it with the rod, and that very, very similar to this one right here. And that's how they fix the hip. So if you see an ORIF, it doesn't mean they replaced the person's hip. It means they just went in and fixed their existing hip bone. Now here's an example of an external fixation. Notice you have the devices on the outside of the person's leg, and you just have rods or screws going into the bone to align it. Now, eventually, of course, after this heals, they will take this external device and they will remove it. Very important, which you want to keep an eye on as a nurse, you don't want these sites right here to get infected. You got to keep those clean and dry and keep a close eye on those. Nursing management. This is actually some nursing diagnoses. So if you ever have, say, a hip fracture, this might be one of the nursing diagnoses you might want to use with it. Impaired mobility, pain, impaired tissue integrity. As you saw from the external fixation, you saw how if there's any kind of open reduction, you're going to have incisions, you're going to have screws, you're going to have open tissue. Now we're going to cover some of that as we go through this on the orthopedic surgeries. We'll be taking a look and seeing how some of this, especially hips and knees. Hips and knees are going to be a big part of your career. So we're going to look at a couple of those. Here's reconstruction of a knee joint. This is called arthroplasty, and this is where they go in laparoscopically and do some repairs on the knees. Now, those of us yesterday, we were talking about Joe Marley. Joe Marley had laparoscopic surgery on his chole. Now, here's a good example of what it might have looked like, because you have just 3 holes in the skin, and one of them blows up air in the area so the doctor can see where he needs to work. He uses a tool for manipulating, and then one of them provides light as well. And I think this tool right here probably does a couple different things. Now, I'm not intimately familiar with laparoscopic, but I've just kind of seen it done. But this way you just have 3 holes poked in your skin instead of a big scar right down the front of your knee, like you'll often see on, you'll see that with knee replacements. Now here, as I was saying, if you have an open reduction internal fixation of a hip, what they did is your hip bone broke right here. And so they'll just put that bone back on there and put a rod in there and fix it. This is not an ORIF. This is an actual hip replacement. This is where we're actually going in. We're cutting off the hip bone completely, and we're putting this metal device in here instead. So when you have a hip replacement, this is what they're doing right here. This is a metal ball, and here's a metal cap that they put in your pelvis so that these two mesh perfectly. Same is true of the knee replacement. Now, this is not going to be done laparoscopically. Here, they're going to have to literally cut open your knee like this, and they put this cap on your femur, and then they literally just shave off the top of your tibia and put this on the bottom here. And this is a knee replacement, very common. We all probably know somebody who's had a knee replacement.
Bryce, can I ask you a quick question?
Sure.
Like with stuff like that, with there being the metal in there, wouldn't you eventually see like bone breakdown with that? I mean, like, is that something you normally see right there?
What I've seen is the bone tissue, the way this is created, the bone tissue attaches to the metal itself and it becomes very strong. But they still have to be very careful, because you do bring up a good point. We have had several cases where, you know, especially little old ladies, where the bone's getting old and the bone's getting fragile, and they step off a curve and this part right here breaks through the bone. And then they got to go in and they got to just kind of pack the bone up around the prosthetic. In general, in a normally a rather healthy person, this bone will attach here very firmly, and it's very good. There's always stuff you can't do when you've had a prosthetic device put in. I mean, you're not going to run a marathon with this thing. I'll tell you that right now. You got to be careful with it. And same is true of the knee. An artificial knee, you're not going to go jogging. Now, maybe some people might know you might know some people who've actually been able to jog with a prosthetic knee. Most people can't. It won't take that kind of impact, and that impact affects the bone down here. And you don't want to risk breaking this device through the bone. So you do have to be careful with prosthetics.
I remember.
Most people getting hip replacements, they're usually not runners or football players or anything like that. But
Is
answer-
there like because you said like as they get older, you know, it gets more fragile. Obviously, like bones get more brittle as you get older. Is there an age that they kind of eventually stop doing these replacements? Like, do they look for certain like health factors in that sort of sense because they don't want to put it into somebody that's like got brittle bones?
If you have osteoporosis, that can be a problem. But the problem is we can't just leave it. We got to do something. You know, if we immobilize this hip right here, it limits their mobilization. They're probably bedridden and they're probably going to be dead in a year. You know, even if their bone is fragile, we have to do something. I don't know. That's a really good question. I mean, it is a risk factor, but you know, it's really you have to do something. You know what I mean?
Yeah. Thank you.
Yeah. Now I'm sure somebody who has osteoporosis and their bone is fragile, they're going to definitely put them on a heavy dose of osteoporosis medicine to hopefully keep that bone. And I don't know if they can like put a metal plate around here to reinforce it. I've not seen that. I mean, maybe that's a possibility, but you know, it's you got to do something. You can't just leave them without a hip. Moving on.
What is his name?
Amputations.
Yes.
Amputations can be caused by a variety of things. It can be tumors, especially tumors in the bone, trauma, car accidents. Where you're probably going to see most of your amputations is it's going to be tissue death due to peripheral nephropathy. Now, I'm sure every town I've ever lived in, there was always one or two homeless people running around the street in a wheelchair. Everywhere I go, you always see that. That is due to amputations due to peripheral nephropathy. They're unable to, you know, eat properly and take care of themselves for their diabetes, and the diabetes eventually kills off their toes and kills off the ankle and kills off the lower leg, and they wind up having amputations. Now, bacterial infection, we've all heard of gangrene. That's why during the Civil War, when you got a wound in an extremity, they usually cut the extremity off because they were really worried about gangrene. And more people in the Civil War died from infection than died from bullets. So, but there again, these two can go together. The diabetic peripheral nephropathy causes inhibited circulation to the tissue, which causes the tissue to die, which could lead to an infection, and that infection could be gangrene. So sometimes these two kind of go together. Common abbreviations for amputations, AKA, okay, I had to stop and think about that for a minute. Above the knee amputation. So if they cut the leg off above the knee, you'll see that abbreviation, AKA. If they cut the leg off below the knee, you'll see BKA. You see those two a lot because of diabetic peripheral nephropathy. Those are very common terms in your nursing notes. Above the elbow amputation, below the elbow amputation, you don't see those as much. There's not as much problem with nephropathy in the upper arms because there's not as much pooling of the blood, not as much pressure. So you usually don't get as much nephropathy in your upper limbs. Although you will see diabetics will get some numbness in their fingers. But AKA and BKA, you'll see that a lot. Trivia. The cooks were usually the surgeons on ships because they knew how to use knives. They're the ones that did all the amputations. What amazes me, and during that time when they didn't have any antibiotics and infection was a problem, the number of people on those ships that actually survived with amputations after having their limbs cut off. It's amazing. I wonder what secrets they knew that we don't know today. Anyway, nursing management. Post-surgical. Okay, post-surgical, we're talking about if they have a hip replacement or any kind of open reduction where they had to go through surgery. When someone comes out of surgery, you always have to keep a very close eye on their breathing because of anesthesia. Anesthesia can affect their breathing pattern. And when they first get out of surgery, you'll always see they have that little breathing device, spirometer. You always want them to breathe out to get their lungs to open back up again. We don't want their lungs to remain closed because what will happen is they get pneumonia, and that's a bad thing. Pain, of course, is going to be an issue. Risk of infection and impaired mobility. There again, if you have any patients with amputations, these are some good nursing diagnoses, which you might want to like stick that in the back of your brain. But post-surgical, this is going to be 4 things that you're going to have to keep an eye on. And there's a little guy. Disturbed body image. That kind of goes without saying. I mean, if you cut off an arm or you cut off a leg, it's going to affect the person's psyche about their self-image. And you're going to have to deal with the psychological aspects of that. Did I get through it all? I did. It's over. Any questions? I try to keep these down to 20 or 30 minutes. How did I do? 38 minutes, not bad.
So I had a question on so excluding like older adults, we all know that older adults can break bones much easier. Are children more susceptible to broken bones than say under 40-year-old adults? Like is that flexibility meaning they're more susceptible to breaks, or is the normal aged adult going to be still pretty susceptible to broken bones? That makes sense.
The adults are going to be more susceptible to bones breaking because in children, the bones are more flexible.
So the flexibility actually works in their favor. So
yeah,
you'll see. Okay.
The flexibility of bones in children is actually nature's way of kind of taking care of them.
Okay.
If you get a green stick break, you're going to get some fragments like break off the bone like that. Usually it'll heal itself. There's usually not much you have to deal with. If it is a green stick break, they'll still put it in a cast or a sling of some type to keep it immobile. So, because you don't want it healing like this, you want it to heal straight. But
okay.
Yeah, kids are amazingly flexible. I'm always joking around. I say kids bounce well. And that's true. I mean, you'll see a young child will fall down and bang their head on the floor. You know, I mean, I would have a skull fracture if I hit that hard. But the children's skulls are still a little flexible. And so it actually just springs. Their skull just they literally bounce. Jordan, you're a bit late. We're all done. Any more questions? If there's no more questions, I'm going to stop the recording.
I have one really quick, Bryce.
Sure.
On the like when they amputate, okay,
Yes.
why are there times that they like will amputate like below the knee and then have to go back in and say, okay, now we need to go above the knee? Like why didn't they determine that in the first place so that we don't have to go into surgery twice?
Because the necrosis advances. You'll see in a typical diabetic with peripheral nephropathy, the first thing that will go will be the toes. Of course, we want to preserve as much tissue as we want to. You know, if their toes go bad, we don't want to cut them off at the knee. But it will progress. So, you know, the first thing to go are the toes. If somebody is diabetic and they bash their foot against the dinner table and it gets bruised, they don't have the blood circulation down there to help it heal properly. So it's open to either tissue dying, and if tissue dies, it'll get infected. The minute tissue dies, infection just starts. Or if they cut their toe on something and they don't have the circulation down there for their immune system to get down there and use white blood cells and stuff to heal that wound. So they're really susceptible to infection. And anytime the infection starts and it starts killing tissue, we have to get rid of it. And if we can't like really hammer them with antibiotics and can't get the infection under control, you have to take the toe off to protect them, because we don't want that infection to spread through the whole body. And especially if it's gangrene, I mean, it can literally kill you. So they start with the toes, and then especially if they don't take care of their feet after an amputation, the infection can spread, and then we have to take off the foot, have to take off the ankle. We try not to take it off above the knee if we can help it. But if the infection, if we take the leg off just below the knee and the tissue begins to die and infection begins to fester below the knee, then we have to take it off above the knee. It's just a progressive steps. I mean, we're always hoping at some point it will stop. And in most people it does. I mean, they'll have a BKA, below the knee amputation. And then when we amputate, we leave a flap of skin, and the flap of skin goes over that, and we sew the flap of skin on there. And if that seals off and heals well, you have a good, for lack of a better term, you have a good, healthy stump. Hopefully it stops at that point. But if the necrosis keeps progressing and anything in that stump gets infected and the tissue starts dying, well, then we're back to the operating room cutting it off above the leg. There are a lot of people out there with BKAs. The AKAs are a little more rare.
And it moves like that quick. Like it can go, because like, so for instance, my father-in-law had it below the ankle, or had his ankle amputated at the ankle. And then they went in like 3 days later and below the knee. And then they went in less than a week later and had to go above the knee.
Yeah. I don't know the particular circumstance, but evidently when they went below the knee, they didn't get everything they had to get off.
Okay.
I mean, we want to cut off as low as we possibly can. Because I mean, if you have a below the knee amputation, you can put a prosthetic on there and you can walk around fairly normal. If we take you off above the knee, there's no good knee prosthetics. It's going to be difficult for you to walk because that leg is going to be straight all the time. So if there's any way we can preserve the knee, we're going to do it. But sometimes if the tissue damage works its way up, especially into the joint, don't have any choice but to take it off.
Thank you.
Any other questions? I'm going to stop the recording.